Welcome back to the Diet Doctor Podcast. I'm your host, Dr. Brett Scher. Today, we're going to talk about kidney disease, and this is the first part in sort of a two-part series of kidney disease. We're going to hear from Dr. Thomas Weimbs, and who's a researcher at UC Santa Barbara, and his dietitian, Jessianna Saville, and about their program and how they approach chronic kidney disease with nutritional therapy. And then in a later episode, we're going to talk to Dr. Keith Runyon, who's a nephrologist and has type 1 diabetes himself and uses a ketogenic diet to treat his type 1 diabetes, and how he uses ketogenic diets for people with chronic renal disease as well. So it's an important topic because we hear very black and white comments that protein's, bad for kidneys, or ketogenic diets may be good for kidneys, or are they bad for kidneys? And you really can't make blanket statements like that because what protein level are we talking about? Are we talking about animal or plant protein? What level of chronic kidney disease are we talking about? And what is the underlying etiology of the kidney disease? All of these things come into play when you're really trying to define the proper diet for somebody who has concerns with their kidneys. And then kidney stones are a whole nother topic as well. And again, what type of stone? And that comes into play for the specific diet. So just like we can't say there's one diet for everybody, we certainly can't say there's one diet for your kidneys as well. And ketogenic diets and high and low and medium proteins all play a role. So let's get into some of the details in this episode and the next episode about chronic kidney disease, or kidneys in general, and dietary interventions. First, we're going to hear from Dr. Thomas Weimbs and from registered dietitian Jessianna Saville, who goes by Jess. So Dr. Weimbs is a PhD in biochemistry from Germany. He did his postdoc at UC San Francisco, then in 2005 moved to UC Santa Barbara, where he's currently an associate professor. He runs his own lab where he focuses on the molecular mechanisms of polycystic kidney disease, which is referred to as PKD. So you're going to hear us talk a lot about that, but also related renal diseases and developing new therapies for these. So first, the difference between PKD, polycystic kidney disease, and CKD, chronic kidney disease, which is basically kidney disease from any cause. It doesn't specify, which of course the most common are type 2 diabetes and hypertension, which together make up 75% of chronic kidney disease. And then Jessianna Saville, who is a registered dietitian and renal nutrition expert. She's at kidneynutritioninstitute.org. They both are involved in Santa Barbara nutrients.com and renew, ren-nu.org. Where you can find lots of information about them and the work they're doing. So a couple things to talk about is, in this interview, we talk a lot about the stages of kidney disease. And it's so important because there's normal, mildly impaired kidney dysfunction, moderately impaired, and severe kidney dysfunction. And really, you got to draw the line between sort of mild and moderate, which is usually what we call like stage 2, stage 3 in that area of kidney dysfunction. And it's usually defined by GFR, or glomerular filtration rate, which is basically how well or how efficiently and how quickly your kidneys are filtering the blood to filter out the toxins and whatever. It's because the glomeruli are where that filtration happens. So that's the topic there, just so you know what those terms mean. And we talk about, 0.6 to 0.8 grams per kilo of protein per day, which is pretty low compared to what Diet Doctor usually recommends. But when we talk about that, that's again in the moderate to severe kidney dysfunction group, really towards the severe. So we'll talk about that as well. So with that, laying the groundwork, let's get into the interview with Dr. Thomas Weimbs and with Jessianna Saville. Well, Thomas and Jess, thank you both so much for joining me today on the Diet Doctor Podcast.
Thanks for having us.
We're excited to be here.
Great. Well, I want to jump in with you, Thomas, and talk about kidney disease. And now your specialty is polycystic kidney disease, but as we discussed offline, you mentioned that you deal with all sorts of chronic kidney disease. And in the U.S. and in sort of industrialized nations, the top two causes of kidney disease tend to be diabetes and hypertension. So tell me how you see the field of chronic kidney disease and the role that nutrition can play in that, and how that sort of led you to where you are today in your approach to kidney disease.
Yeah, great question. As you know, chronic kidney disease is actually very, very common. Affects over 10% of the population in the US and worldwide. So most people, tend to forget that oftentimes. It's very, very common, sort of like epidemic levels, if you will. And as you mentioned, diabetes, hypertension, the most common causes. What we have been focusing on is a genetically determined form of chronic kidney disease, polycystic kidney disease, or PKD, where the patient inherits a defective gene from one of their parents, has a 50-50 chance of getting the gene, developing the disease. It affects about 600,000 people in the US, so it's still fairly common. But really, the gene mutation essentially kicks off chronic kidney disease in these patients. And, it's maybe much more predictable than diabetic chronic kidney disease, if you will. So if you have the gene, you have the disease. That makes it, of course, a little easier to study, a little easier maybe to do clinical trials with, and so on. And we have been studying polycystic kidney disease in the research lab for 20 plus years or so. And we've been using mouse and rat models of the disease. So obviously you can replicate the disease in those models with by introducing those gene mutations. So things can be studied maybe in a kind of refined way. Essentially what we find, I think, initially, we think it holds true for polycystic kidney disease, but since the mechanisms of progression in chronic kidney disease in general, including PKD, are essentially the same. There's the same molecular pathways and so on. We think that whatever we would find in polycystic kidney disease has a high chance of being, translatable to CKD in general.
Yeah, that's interesting. The overlap between polycystic kidney disease and chronic kidney disease. Although I'd imagine the worst case scenario would be someone with polycystic kidney disease with diabetes and with hypertension. That would be sort of a recipe for disaster, I'd imagine. So it seems like there's kind of two approaches, though. One approach would be to do whatever you can to treat diabetes and hypertension. And the other approach would be to do whatever you can from a nutrition standpoint to protect the kidneys themselves. Which sometimes might be two different dietary approaches or a single dietary approach. So Jess, let me ask you, from the nutrition side of things, how do you see the nutritional approach to chronic kidney disease?
So this is a great question, and I want to answer on two layers, also layering with polycystic kidney disease. So when Dr. Weimbs' research came out in 2019, our practice was really, really heavily involved with plant-based diets. That's, the word on the street in the kidney world. That's the hot topic. That's what people are doing. That's what research has supported. And so looking at the ketogenic research in particular, I was like, this is going to be tricky, right? How are we going to do it? There's so much evidence to support kidney function from a plant-focused approach. And yet the dietary, the emerging evidence is showing that ketosis is going to be beneficial for PKD. And I'll be really honest, Dr. Scher, for our folks with PKD, we hadn't been seeing great results with a plant-based diet. Like, we just weren't getting the same results, and I could not figure out why. So our challenge was, in looking at this approach, is we had to look at not only for polycystic kidney disease, what are the kidney stressors? And for us, that means we have to get the protein level down a little bit lower for especially people with later stages. And, we use that approach across, PKD, CKD, but the protein amount's pretty important. And then we had to think, how could we keep it very plant focused? And merging that into a ketogenic diet took a good bit of work and thought to make sure that it wasn't a malnourishing diet, and it was also a doable diet. And that was, part of our process is avoid kidney stressors, but also how do we prevent progression?
Yeah, I think that's a great way to sort of spell it out in terms of, the two different focuses. One, as you said, being plant-based, and one being the ketogenic diet. And although the other, I guess the third being sort of lower protein. Now, the way I see kidney disease and kidney health as it terms to protein, which is such a hot topic right now, the way I see it is that if you have normal kidney function, or even sort of mildly diminished kidney function with low GFR, that the protein is not so important from that standpoint. But once you get past that mild kidney disease into moderate or certainly severe kidney disease, and I imagine this holds for polycystic kidney disease, then protein does become more important, and lowering the protein level can help prevent further deterioration of GFR or kidney function. Now, does that summary sort of hold with the way both of you look at it?
There's two issues there because it's one, the macro issue, right? Macronutrients, how much macro protein is involved in the diet. And yes, what you said is true for a lot of people is that at higher stages, the protein is not so much an issue, and are really careful with how we use plant-based diets and that approach. The other thing that's interesting, and with polycystic kidney disease in particular, the research doesn't hold as consistent with like a very restricted protein intake as it does for CKD, especially for the higher stages. So that's one piece of it. The other piece, though, that we're considering is what protein in and of itself has that might be a kidney stressor outside of amino acids. So, for example, very protein heavy diet can be quite acidic, and where metabolic acidosis and alkalinity is really important for PKD and CKD. That's, another way that we're looking at how those two balance.
Okay, yeah, I just want to get back to that the acidity standpoint, but Thomas, do you have more to add there?
Well, regarding protein, I think there's also a bit of a difference in the quality of the protein, whether it's animal protein or plant-based protein, because typically protein sources from animals are much higher in the amino acids cysteine and methionine, which just happen to be metabolized in such a way that they are very acidifying. So it leads to a much more acidic urine pH, which then in turns lowers urine citrate levels. So it causes sort of a certain degree of hypocitraturia. And all this together increases the risk for kidney stone formation. And even prior to getting a kidney stone, there are all these microcrystals that can form in kidneys, such as calcium oxalate and uric acid microcrystals that are all much more likely to form under acidic conditions. So I think that's maybe, and that's actually the reason, maybe one of the main reasons why in chronic kidney disease, one would choose more plant-focused diets to kind of stay away from these acidifying proteins.
Yeah, that's a great point. We again, sort of two different things to look at. One is further progression or worsening of actual kidney function, which we estimate by the glomerular filtration rate. But the other is formation of kidney stones. So, but when some people hear plant-based for kidney stones, they would think like oxalates. Oxalates come from plants. Calcium oxalate stones are the most common stones among anybody. So is that a problem when you go to a more plant-based diet? If you're eating lots of spinach and lots of nuts and things that have oxalates, is that more of a concern?
That is a concern, exactly. That's why I think Jess and her team had to work really hard to make this work, because just as you said, if somebody hears, oh, I want to switch to a plant-focused diet, the first thing they say is, oh, let me eat more spinach and more Swiss chard and more nuts, this and that. And then before you know it, your oxalate intake goes through the roof and everything backfires. So that took, I think, Jess and her team, and she can comment much better on this, quite a bit of work to try to exclude or limit those types of plant foods and find others to replace with.
Yeah, the trick for us, we're kind of the rubber hit the road here, is we thought, okay, if you're gonna do a plant-focused approach, we actually tried to make it 100% vegan at the first, and it, A, was not nourishing, and B, it was miserable, and C, we didn't have any way to balance out the oxalates, because oxalates is not just about how much you intake from your food. It's about how much you bind in your gut. It's about your gut health. It's about how acidic your urine is, so you don't develop crystals to begin with. So there's, those three big parts of oxalate management. And so when we look at, a plant-focused ketogenic approach, we look at oxalate management, not just restriction. That's very, very important. I'll tell you though, the one part that's really tough on a keto diet that's oxalate managed is eliminating almonds because they're in all the keto food. They're so simple and easy and like they just fit in a lot of keto diets really nicely, but they just don't work in ours. So we do no almonds in our diet.
Yeah, so you mentioned it's about sort of oxalate management rather than oxalate
Yeah.
restriction. So what helps with oxalate management?
So there's a couple different layers. So number one, calcium and magnesium combined oxalate in the gut. So that's number one, is that if you're going to eat a heavy oxalate source, that having some sort of calcium with it is very, very important. Or that's how we teach our patients. So we don't do a totally plant-based approach because we really needed some of the dairy products that have a little bit more calcium in them to balance that out. So there's number one, binding it in the gut. Number two, making sure that the gut is in good shape anyways. The microbiome, it always comes up, but you have bacteria in your gut that generate oxalates. So if your gut is kind of a disaster, you're going to be at more at risk of that, of a heavy oxalate load. And then the third thing is making sure that your urine is, pretty alkaline. And you can do that by having a good amount of citrate in your diet, also by just having a heavy plant base as well. And, that's where, Thomas's research and Santa Barbara Nutrients research has really come into play to develop a product that can kind of cover all the bases there, and that makes it really simple. But there's a lot you can do with diet too.
Yeah, that makes sense. So Thomas, tell me about the difference between acidic blood and acidic urine, because we have so many sort of checks and balances in our system to try and keep the acidity level in our blood pretty consistent. And I don't know, my take on the literature is that the acid base of the blood doesn't change a whole lot with dietary components. That's how I read the literature. I'd be curious if you think differently, but I haven't looked into as much how it changes the acidity of the urine. So can the urine be more affected than the blood, and tell us a little bit about that interaction?
Yeah, you're absolutely right. Usually the blood pH level is just like rock solid, and for good reasons, because if it deviates a little bit, you're dead. So, bad things happen. So usually I don't think it's very easy to affect blood pH level with diet at all. That may not be a thing at all. But the function, one of the important functions of the kidneys is to actually regulate the blood pH level by excreting more acid or more base, depending on the need. And that's so in a sense, the urine that's produced becomes flips up and down in the pH, and it can happen throughout the day, and it just depends literally on what you eat, a lot of that. So the urine pH is really what we're talking about when we're talking about an acidifying diet. It's not about the blood pH, and it's always the urine pH. Yeah, and it just so happens that ketogenic diets in general, or just being in ketosis, is actually just by itself acidifying, because the ketones, are acidic, and essentially you're turning a neutral triglyceride into acids. So usually, if anyone is on a ketogenic diet, you tend to have a much lower urine pH. And if it's then on top of that a meat-based ketogenic diet where you have all the cysteine and methionine in there, it makes it even worse. That's probably one of the reasons why sort of like a heavy animal-based ketogenic diet may not be the best choice necessarily for somebody with kidney disease. On the other hand, you do other good things with it. Usually, you obviously cut out sugar, which tends to, not elevate your uric acid anymore, and those kind of things. So there's a little bit of a balance in there. So I wouldn't say an animal-based ketogenic diet is necessarily terrible for kidneys. But if somebody has chronic kidney disease, I think you'd want to be careful there, and that's the reason why we're going the plant-based approach. Or it's not plant, but it's plant-focused.
Right. To get back to what you said earlier, Justin, you said you weren't getting the results you had hoped for from just a plant-based diet by itself. But when you transitioned to a ketogenic version of a plant-focused but not completely plant-based diet, then you started to see better clinical improvement. So I'm curious what you think it was, both of you actually, what you thought it was about the ketogenic diet, about being in ketosis that made the difference. Was it just getting rid of the sugar, like you just said, Thomas, or was it something else about being in ketosis that can help with polycystic kidney disease or chronic kidney disease in general?
Maybe you can start there. So this came out of my lab's research on animal models, where we initially found that reducing food intake turned out to be tremendously beneficial in polycystic kidney disease. We initially published a paper, and we had no idea why this actually worked. And then we followed up with the research to figure it out. And it turned out that it's really the metabolic state of ketosis itself that seems to be highly beneficial in polycystic kidney disease. And we were even able to replicate the beneficial effects by just supplementing with beta-hydroxybutyrate just by itself on top of a regular high-carb rodent chow. Suggesting that is really something about that, about the metabolic switch from glucose, away from glucose towards ketones. And of course, as you know, BHB, beta-hydroxybutyrate, is not only a fuel that is burned for energy, but it also is a very potent signaling molecule. It is has pretty potent anti-inflammatory effects. And inflammation is already known to be a very important contributor to chronic kidney disease and PKD in particular as well. So we think it's really, that aspect of ketosis itself that is beneficial.
I'll just share a couple anecdotes that I think are important here, and not so much on the mechanism, because I think Thomas described it pretty well, but for people with polycystic kidney disease, it is a slow march down to dialysis. Like, that's basically the story that they see from their relatives. Remember, it's genetic, so they will have seen their aunt or their grandma or their mom or dad struggle with it. And for us, starting to see patients where their GFR would actually bump up. Like, we start the approach, and 6 to 12 weeks later, we start seeing people's GFR improve. That was, even if it just stayed stable for some of them, that was a huge, huge win. And I think some of that is that mechanism of, obviously how glucose feeds cis. I think the other thing for a lot of people is that as you start pulling in like a heavy amount of plants, plants are so nutrient dense. And, I know there's a variety of opinions from people in the carnivore world versus plant-based, and, there's swirlings of opinions. But the reality is that plants hold many, many powerful nutrients, whether that's helping your liver work better or just nurturing your gut. Because, again, there's a strong connection, I feel like, with PKD and gut health for a lot of different reasons. And so I think there were just a lot of different pieces that could play into it. And, on our side, one thing that we're watching in our patients, since this is a new approach, is what their kidney volume actually looks like. And we have had some people now on the approach over a year, and their kidney volume hasn't changed. And like that, like more than GFR, that is really, really significant finding.
Can you describe what kidney volume is and how you test for it?
Sure. It's, so done, and Thomas, just correct me if I get something wrong here, but they usually do a MRI or a CT scan, and they can measure the size of the kidneys. And, polycystic kidneys can get really, really big, really, really big. Some women, they complain because it makes them look like they're pregnant, actually, and they'll complain of, PKD belly, or, cause a lot of pain because they get really massive just because of the cysts growth getting so big.
Yeah.
But they measure, the size of the kidneys, and they can measure how big the kidneys are. I think some of the more advanced imaging can, get like a good, like, volume, what is the actual volume in the kidneys, and they put that as the measurement.
Right. Yeah. Yeah. It's the total kidney volume. That's an important thing in polycystic kidney disease, because in contrast to many other forms of chronic kidney disease, in PKD, the kidneys actually expand over time, and
Yeah.
they can get massively large, as just mentioned. So that's one of the measures of progression in polycystic kidney disease, is not only the kidney function decline, but also just the increase in total kidney volume. And maybe one thing to add also is, when we published our paper using the animal studies and on the beneficial effects of ketosis. Of course, patients are smart; they read papers as well, and kind of the news spread like wildfire. That there's this paper out there saying that ketosis and ketogenic diets are beneficial in these animals with PKD, and lots of patients started to just implement it on their own, and they're Google around and find different recipes, and I think it was a little bit of a Wild West scenario almost. Doctors were not necessarily wanting them to do that. So it turns out that a lot of PKD patients had already experimented with ketogenic diets, and we were actually able to recruit about 130 of them into a retrospective clinical study, just to see what their experience has been. And the results were actually quite stunning. So I didn't expect it to be so clear cut. The paper was published just recently. There were the average duration in the study of people being on ketogenic diets was about 6 months, so decent time. And it's kind of self-reported outcomes, questionnaires on pain and different symptoms of PKD, but we also collected the medical data, the glomerular filtration rate data, and blood pressure and so on. Everything across the board improved, strangely, interestingly, including even the kidney function metric, the glomerular filtration rate based on creatinine, which is somewhat unheard of. That usually does not happen in polycystic kidney disease. It's a relentlessly progressive disease that essentially never gets better. In those patients, at least, it got better for many of them. So,
well, that's really interesting, because I'd imagine if people started themselves on a keto diet, it was not likely going to be a plant-based keto diet, because that's usually not the default that people go to. And it probably wasn't a low-protein keto diet either, and yet there was still benefit. So I think that's a really interesting finding.
Right. Yeah, I totally agree. So, also, there's a little bit, so the GFR, the glomerular filtration rate, is essentially measured by measuring creatinine, which indirectly is somewhat affected by the meat consumption. So somebody could argue, maybe you saw the improvement because of the change in diet. But as you said, if somebody starts a meat-heavy ketogenic diet, you would expect the opposite effect. So I think that makes it pretty interesting as well.
So findings like that have been really important because it's helped us kind of stratify how restrictive we need to be with the protein. One thing that worried us as clinicians is we'd see, different people come in, and we work with a lot of people with late stage, like GFR less than 20. But we would see for them that when they did go high on their protein, that they could totally knock out their kidneys. And we had people that came in and their kidney function was like dropping like a rock really fast because they implemented a ketogenic diet and it was very, very meat heavy. And now they were like on the verge of, dialysis decisions. And so I think clarity from both sides of that for who can get an impact without being very restrictive is really important for quality of life and long-term engagement, versus who does need to be really careful with the protein intake. And if you don't have, if you can't go to lots of chicken and fish and, even bacon as like your keto foods that satisfy you, how are you going to make that dietary approach work? And so we wanted to address it from every stage. And, it's really interesting when we look at some of our later stage people and what's happened for them. in the approach because, people will go on and off. And so we've seen the impact of higher protein, lower protein, stay in ketosis, don't stay in ketosis. And we've started to develop more clinical judgment around that.
Yeah, well, that's really interesting. And I think that comes down to, how we oftentimes try to simplify things too much. And I say we as like the medical community in general, like protein's bad for kidneys, or, keto's good for kidneys, or, whatever. But it's not that kidneys are one thing. So we really have to be clear about where you are on that spectrum, from normal
Beautiful.
kidney function to dialysis and somewhere on that spectrum. And that's going to make a difference. So we've talked about protein quite a bit, high protein, low protein, but give us some numbers of what you tend to shoot for with your patients with PKD, because we know too low of protein could lead to sarcopenia and loss of lean muscle mass. So you don't want it to go too low, but then in that chronic kidney disease population too high, like you're saying, could potentially harm kidney function. So what's your sort of sweet spot that you aim for in that kidney disease population?
That's a great question. So we just analyzed this last week. We had built the approach off of some pretty strong concepts, and then we went through all of our Renew participants, people in our group programs, food logs, because they take actually great food logs, which gives us tons of information. And we looked at what is, in this approach that's plant focused, what is the average protein? And we were getting around zero 0.6 to zero 0.8 grams per kilogram, which is drastically different from like Bulletproof, for example, is 1.5 to 1.7 grams per kilogram. That's about what they end up shooting for. And a normal protein intake's around 0.8 to 1 gram. So kidney guidelines right now support a 0.6 to 0.8 gram per kilogram. And we were hitting that like spot on. So for our people, especially later GFRs, that's what we aim for, 0.6 to 0.8 grams per kilogram. That ends up being somewhere around, it actually mirrors the net carbs kind of closely, which is funny to me. But, for someone who's on, around 2,000 calorie diet, they have, ours is a more liberal keto approach, obviously for plant-based reasons. They end up hitting around 35 to 40 grams of net carbs, and their protein ends up being somewhere around there too, 35 to 50 grams of protein a day.
Yeah, so for me, like that sounds just so low. But of
Right?
course, I don't really deal with people with PKD and chronic kidney disease, so I don't see them very often. So, do you have concerns about lean muscle mass loss or frailty or sarcopenia as some of these patients age and move on eating that much protein?
Yeah, that's a really, really good question. And malnutrition is the hottest nutrition topic in kidney disease for sure, by far. But there's a couple of things that we've seen is number one, we haven't seen a lot of lean muscle mass. Um, some of that, muscle mass loss can come when people get too restrictive with their calories overall. And so if we start seeing like lean muscle mass or people losing weight or losing strength, a lot of times, honestly, we can balance it out with increasing their calories. And for some people, we do increase their protein level. For some people that are later stages, we don't increase the dietary protein intake, but we might add on what's called a keto analog amino acid. So that's basically amino acid supplement without nitrogen. So there's a couple different ways that we can address that. And it's, a weekly question for us when we're working with our patients, like, how is your weight? How are you feeling? How's your strength? We actually have many of our patients with polycystic kidneys that come in. They're quite fit, very active. And so we can assess that. And, we haven't seen a lot of problems with that, honestly.
Yeah.
That hasn't really been an issue. And again, like numbers are slightly arbitrary. And that's where good clinical judgment comes in. Cause for some people, you say, hey, like, you probably need to do a little bit more protein. So, like, let's add it in. Let's watch your numbers. Let's see how things go. And so it's one of the things to work on. The one piece that we have been particularly mindful of recently, and this is really, really important with the ketogenic diet, is meat is a very significant source of carnitine, right? Like that is one of the main ways that we intake it. When you're on a very low protein diet, you have to be very, very mindful for your patients of if, that they are getting carnitine in. And I mean, already, supplementing with carnitine for keto is pretty regular. But for us, it's standard. Like almost every single person, if they're bringing their protein down that low, we have to add in some L-carnitine.
Now, Thomas just mentioned about the 0.6 to zero point 0.8 grams per kilo as sort of like the kidney recommendations for people with chronic kidney disease. Is
Yeah.
that the standard recommendation? Thomas,
Mhm.
do you think that people could go higher if it was, more soy-based protein, more pea-based protein, that pushing that to 1 or even maybe 1.2 grams per kilo wouldn't have the same effect on kidney function for people in chronic kidney disease compared to if it was an omnivorous approach?
Right. Yeah, no, I think you're absolutely right. There is actually, for earlier stage CKD patients and PKD patients, there is not a very strong correlation between protein intake and and the outcomes there. So that had been controversial a few years ago, and I think it has been now settled that there's like really not a very strong link there. But the equation changes as soon as somebody gets closer and closer to renal failure. Then everything changes, with nutrition in those patients. I think Jess is in particular talking about folks that are, at CKD stage 3 and so on, and sliding towards 4, where it becomes much more restrictive over time.
Yeah.
So probably earlier stage. And the thing about patients with PKD is they typically are diagnosed fairly early. So even if they have perfectly intact kidneys, they're still at CKD stage 1 or 2. They already know they have the disease. So I think at those stages, I don't think there's much need to restrict protein too strongly. But what is probably still a good idea is switching over from animal-based protein over to plant-based,
Yeah.
just to prevent those, kidney stoning and crystal issues.
Okay. Yeah, so let's transition to again to go back to some of the practical aspects of it. So if we're talking about starting a plant-heavy, plant protein type diet for people with chronic kidney disease, what are the main go-to sources of protein, and what are other supplements? You already mentioned the L-carnitine. What other supplements do you need to focus on?
Yeah, so to answer kind of go to. So for us, I'll just give you an example of what a day would kind of look like. So a lot of our patients, and I'm like literally thinking of the pictures of the meal plans in my head. They might start out their day with a very fat heavy smoothie. We use a good amount of coconut and coconut milks. They might start with a very fat heavy smoothie. Maybe they'll do some eggs with a lot of vegetables in them. They might do cauliflower porridge in the morning and, load it up with extra fat. That would be a breakfast type option. Usually for most people, it's around, 10 to 15 grams of net carbs. And then for lunch, it often would be a very large salad of some sort. We have a keto club salad that people love, or people do a stir fry, and they might use some nuts there as a protein, or a very this is not common. On occasion, our patients will do a really, really small amount of legumes, but that's not their favorite way to use carbs, so they don't do that all the time or put an egg on it. Really heavy on the dressing, a lot of good olive oil we'd use there. And then, for dinner, they people would do a salmon, or some people like to do a small amount of shrimp. Some people will do a little bit of chicken. We do tend to focus more on fish as our protein source, but they might do salmon, especially because it's so fatty. You do a great sauce with it, a good amount of sautéed vegetables on the side, and then we fill in a lot of the calorie holes with like sunflower butter fat bombs. We have some really good lemon blackberry fat bombs that they'll utilize. Um, we use we do like a pesto mayonnaise that they'll dip vegetables in. That's out of this world amazing. Like the diet is so delicious because fat's just really good. So
Yeah.
that's what they would look like. I mean, honestly, when we mapped it out, it is about 50% plants. People are getting, 35 to 45 grams of fiber a day. It's just very nutrient dense, very colorful, very pretty.
Yeah.
Um, and then on supplements, we always make sure they have a B complex. That is a standard supplement, L-carnitine. We'll use either calcium citrate or we use Keto Citra, which is Santa Barbara Nutrients product, which is a BHB citrate product. And that helps us make sure that we have a oxalate binding source on board. So those are like the three essentials must have. And then, clinically, you might look at vitamin D status, and that's pretty regular.
Right.
Zinc we also use on a pretty regular basis, not long term, but I do feel like it's super hard to get enough zinc in without some good, heavy, meat sources.
So interestingly, you mentioned eggs and salmon as some common
Yeah.
protein sources. Now, I
Yeah.
think of those as animal-based protein sources, but do those have less of a urine acidification effect than meat or chicken or other sources? Is that why you go to them?
No, so when we're looking at this approach again, like remember I said that we tried to do it totally vegan. And when we looked at
Yeah.
even like the amino acid content or just how palatable it was going to be or what it was going to look like, it didn't look very good. Honestly, I just feel like we would have been robbing Peter to pay Paul. So we looked at what are what are the protein sources we get the most bang for our buck on an animal source. And so we weren't looking so much at because we knew we were going to be so plant heavy. Are these like the least, acidifying or whatever? We're looking at where do we get really like tons and tons of benefit? And fish and the omega-3s in there are really, really powerful. And so we thought that is, that's one that we can add in. It's simple for a lot of people. So we added in more fish sources. And then eggs as well. The choline to me is really important in eggs, and it's just hard to get choline without animal sources, honestly. I mean, like 5 cups of quinoa, but you're not going to do that on a keto diet. So we put eggs in. They're also easy, familiar for people. There's tons of stuff you can do with them. So that's why we picked eggs as another source that we could utilize. And so far, that's worked out good for our late stage people. So it's not 100% vegan. We also use, I didn't
Yeah.
mention this, we use some cheese and cheese just because cheese is pretty amazing. And so we use cheese in there and we'll use some full fat cream, some, grass fed butter. Works really good as well in the approach.
Yeah, and I like how you're really blending sort of the science of what you need to do with the practical nature of what are people going to eat, because
Yeah.
you can find the most scientifically backed diet that's the best in the world, but if it doesn't taste good, it doesn't matter because nobody's going to eat it. So I really
Right.
like how you have that approach. So I think that's really helpful.
One other thing is that when we developed the approach, we did it. Like, I mean, Thomas has done the approach with the class. Diana Bruin, who's one of the PKD experts, she did it. I've done it. Like the food's good. Like we create our own recipes and we like them. And our patients regularly tell us that they're like, "Man, this food is so good. My family likes it. We like it." And it's just you have to change your lifestyle a little bit to love food and not put it as a back.
Well, this has been great. So everybody should definitely check out Renew, ren-nu.org, and SantaBarbaraNutrients.com and KidneyNutritionInstitute.org. 3 great sites to see what you all are up to. But so Thomas, tell us what's coming next for you, either from a research standpoint or academic standpoint.
Yeah, so in my academic lab at UC Santa Barbara, we're trying to understand the actual mechanisms. Why is ketosis beneficial? Is it really the BHB? Is it BHB acting on its receptor? Is it BHB doing one of the many gazillions of other things that it can do? And then in the as a startup company, Santa Barbara Nutrients, the focus is really we've produced this medical food, Keto Citra, that Jess mentioned, and we're gearing up to do a clinical study at the University of Toronto. So that's the whole Renew program. Together with Keto Citra as an integral part, and we'll test this in patients with polycystic kidney disease. So I'm excited for this clinical trial to get off the ground. We're also looking at other types of kidney disease. One that I'm very excited about is uric acid induced chronic kidney disease. Patients with gout. very, very often go on to form chronic kidney disease. And I think the reason is simply these uric acid crystals that just shreds the kidney to bits and cause microscopic damage that just keeps on, injuring the kidney over and over and over again. And that should be addressable with a similar alkalinizing diet, plant-focused diet, including this medical food keto citra. So I'm kind of very excited about tackling that as well.
Very interesting. Yeah. Well, I definitely look forward to seeing what comes next from you and you as well, Jess. So thank you both so much for joining me. And like I said, anybody who's interested in learning more can check out any of those websites, and we'll include links to them as well. But thank you so much for taking the time today.
Thank you, Brett.
Thanks, Dr. Scher. Really appreciate it.